We will start our session on liver. Our respected chairpersons are Dr. Saket Kumar, Dr. Alok Banerjee, Dr. Sandip Chakrabarti, Dr. Amit Rastogi, and Dr. Mohammed Naeem.
Good afternoon, gentlemen, ladies and gentlemen. This is our liver session, post-lunch. I know plenty of people are already dozed off after having the lunch, but I would like to call Dr. Naimish Mehta to present his biliary reconstruction after LDLT, various options, choices, and outcome. Dr. Mehta, please. Welcome, Dr. Mehta.
Thank you so much. I would like to thank the organizers for inviting me for this meeting and allowing us to show our video on biliary anastomosis post-liver transplantation. So just to point out that there is always a variation in the hepatic hilar anatomy. You will get A1 in most of the cases on the MRCP or cholangio, but may be different. So a detailed anatomy of the hilar variations and knowledge is equally important before you go ahead. Various techniques of biliary anastomosis have already been published in literature way back starting in 2004. High hilar dissection, which is one of the most preferred, and most of the LDLT centers now follow it. And Koreans have also come up with telescopic tailored reconstruction approach. So this is what they had initially defined and described in 2010, where you take a larger cuff of the recipient duct and then anastomose to the hilar duct. The main technique in the donor division is you do a minimal hilar dissection in the donor. Do not dissect off the right hepatic artery from the hepatic duct in the recipient. Stay close to the right hepatic artery, leaving enough tissue around the bile duct and their branches. And when we come to the advantages of comparison between duct to duct and duct to jejunum, there is always, it is better because it is more physiological, preserves the continuity. You can have access to it post LDLT in case you require to put a stent across, and it is a shorter time period as well. So this is the video which starts with a high hilar dissection. That's the bile duct which is being dissected right up into the hilum, and that is in the donor where we have looped. The yellow loop is actually the bile duct. A sharp cut is made on the right hepatic duct. Try and avoid any injury or negotiating towards the left, because you may end up having a short left duct or may need to do a hepaticojejunostomy. The hilar plate in the donor is very vascular. As you can see, there will be some amount of bleeding. We are reconfirming this with a Watson chain, checking that there is a good enough length. The continuity between the CHD and the LHD is maintained. And there again, after the whole transaction, it is again reconfirmed. This was the pre-op cholangiogram, intraoperative cholangiogram. You perform it after transecting the duct as well. And check whether your left duct, you are far away from the left duct, and the left duct continuity is well maintained. On the bench, again, you check. In this patient, we had got two ducts. So that's the right posterior duct. If you can appreciate, it's in the right posterior duct. There it is going behind, and there you can see it, some indentation on the surface. And here the probe is going into the anterior duct. So again, this was reconfirmation, and now we are starting with the anastomosis. So what we do is we take the anterior placed stitches. The centermost stitch is taken first to keep the mouth of the bile duct open. Then the corner stitches are taken at 3 o'clock and 9 o'clock. So first at 12 to keep the duct open, then at 3 o'clock and 9 o'clock. And then in between, you figure out how many you want to place. This is a decent sized duct, so we have placed 3 on each side of the middle stitch, that is between 9 o'clock and 12 o'clock, 3 sutures on the anterior side, and again between 12 o'clock and 3 o'clock, 3 more sutures will be placed. So in this case, this was a single duct, hence a duct-to-duct anastomosis was planned. And now once the pre-placement, the anterior sutures are already pre-placed, you check for the hemostasis which is already achieved, and you take the corner stitches on the recipient bile duct. Here what we are doing is a mucosal eversion. If you can see that, I hope you can appreciate it from behind. There is a mucosal eversion being done. The middle stitch is again being taken at 6 o'clock from the duct and now into the hilar duct. So recipient duct to the donor right hepatic duct. And similar process how we place the stitches in the anterior wall, we place the stitches similarly on the posterior wall. The only difference here is you actually evert the recipient mucosa if possible, and then between 3 o'clock and 6 o'clock you again place the same number of stitches, that is 3 stitches what you had pre-placed between 12 and 3. So here it will be between 3 and 6, and we come from left to right. So away, if you start from away from your body and then come towards your body. All these stitches, again you need to be careful that you don't cut through the bile duct. The right duct is small and can be friable in certain cases. Once you have completed the posterior layer, we start tying the knots. In our case, what we normally routinely follow is the knots are inside the duct, and we routinely take about 4 knots on a 6/0 PDS being taken. Once that is done, we try to cut as close to the knot as possible. So now the posterior layer is complete, the knots are being cut, and then we reconfirm the patency of duct on both the sides. The donor duct is again smaller, so a lacrimal probe is being used. And then we start whatever pre-placed sutures were there. You start from 2 o'clock, the corner was at 3, so you start from 2, 1 and 12. You start coming towards yourself. So all these stitches, and in the anterior layer, we normally do not place a center stitch because they are already pre-placed before on the donor duct side, and that can jumble up all your sutures. So we start coming one by one, and you need to bear in mind that an appropriate number of sutures are to be placed, so an adequate distance need to be maintained from the sutures compared to the previous suture. And once that is complete, we start knotting the anterior layer as well. Again, here we take a good enough bite on the recipient duct so that the recipient duct overlap. Once you complete partial tying of the knots, we again recheck, as you had seen with our arterial dilator, we had rechecked the patency both sides. The reason why I do it is I want to check that there is no back wall knot which we have placed inside is taken while you are trying to knot the anterior layer. So that's a completed duct to duct anastomosis. And hemostasis on the ductal side was achieved before. This is another case where we had 2 ducts on the right side. So that's the intraoperative donor's picture or a video where there's the right posterior duct and the right anterior duct. Both were cut, again both being probed. This is on the recipient side. After doing the anastomosis, we are again probing and showing the duct. They are far apart. Once they are far apart, you need to decide. One will be duct to duct anastomosis, which is already completed in this case. And then now we are showing you the hepaticojejunostomy. So what I do when we do a hepaticojejunostomy, we take a bit of the mucosa on the jejunum and try and cut it to avoid that mucosa pouting into your anastomosis, and sometimes smaller ducts it may be difficult, it may block that and plug it. So I normally cut a part of the mucosa, and then again the corner stitches are placed. The pre-placement of the anterior layer is already being done, and the corner stitches now are being placed. That's a posterior wall. 6 o'clock middle stitch is being taken. So that's again the posterior wall. You start from the jejunum and take the knot inside the right hepatic duct. So again here also the knots will remain inside. Many other different centers prefer to keep the knot outside. So whatever you are comfortable, we do not advocate that you have to follow the same technique, but whatever you are used to doing it, or what you have seen or what you have learned, you can continue following that, because this is one anastomosis that how much ever we try, various centers have published their work, but there is still a good amount of biliary complication which ranges as high from 3% to about 25% in post LDLT, especially in post LDLT scenario. So again here, once partially this is the posterior layer is complete, checking the patency on the jejunum side, and then again we'll be checking the patency on the ductal side, and then we start with the anterior wall stitches. So now again you need to take the jejunum closer every time you have done it. Your knot, when you tie the knot, it has to be in such a way that you push the jejunum towards the right hepatic duct. So as you can see, my index finger is trying to push whenever I am tying the knot. The index finger is pushing the jejunum. It's similar what you would do in a hepaticojejunostomy for a benign biliary stricture. The only difference here is the ducts are reasonably small, especially in a partial graft. And that's the completed anastomosis. In this case, we thought we will try and hitch up the jejunum also to the hilar plate further up to avoid any tension on the anastomosis. So we have just hitched up the jejunum there. So as I said, what you are following in your own center, please continue doing that. And this is what we normally follow at our own center. So thank you very much. And we'll be happy to take any questions.
Thank you very much. It's a lovely video representation of biliary anastomosis and LDLT. Now, do you normally do the arterial anastomosis afterwards?
No, here I have not shown. Arterial anastomosis is already completed.
Already?
Yeah.
Right.
So the routine is you first do the venous anastomosis, followed by the portal vein anastomosis, then arterial anastomosis,
and then the CVD at the last.
Yeah, biliary anastomosis is the last, unless you have actually done a dual left lobe. So if you have done a dual left lobe, you have to flip the liver, and that is the case where you will have to do a biliary anastomosis much ahead of doing the vascular anastomosis.
Thank you. Any questions from the floor? And what is the...
you had a question, Sudeep?
Any stricture rate post-transplant?
So in our center, we have about 15 to 20% biliary complication rate, which includes both bile leak and biliary stricture. So the bile leak is obviously commonly seen immediate post-operative period, and the stricture rate is seen as late as 1 year down the line post transplant being done.
So how do you tackle with it? Because if it is bile duct to duct anastomosis, obviously you can access.
Absolutely. So that is one of the major advantages which I try to point out in the presentation, is that if you have done a duct to duct anastomosis, your endoscopist will have an access. It would be easier to do ERCP and stent across. In case they are not able to do it for whatsoever reason, then in that case you have to go ahead and rely on PTBD, that is percutaneous transhepatic biliary drainage. So our interventional radiologist guy will come in the picture, help us and put in a tube, and then with a rendezvous eventually you'll be able to do it with both the ways, unless it is a plain direct edge. So if it is hepaticojejunostomy, you don't have an option of doing an ERCP or asking your endoscopist to perform. So then in that case you will have to go ahead and do straight away PTBD.
How do you differentiate the bile leak from the raw liver surface or from the anastomosis? Do you do an MRCP?
So there are a lot of modalities which many centers try to adapt, trying to do MRCP, try to do a HIDA scan, but believe me, none of these will be able to tell you the difference between whether it is coming from the cut surface or whether it is coming from your anastomotic site. So the only other way is usually the cut surface leak usually stops And during your transaction and even after your reperfusion, you need to check if there are any bile spots, yellow spots being seen, try to suture it. In some cases where you are doubtful, then you can apply fibrin glue if at all you are comfortable with that. But leak from your anastomosis is likely to persist, and if you have got a duct to duct and if you are doing an ERCP, you do a cholangiogram, that is what will define a leak from your anastomosis.
Thank you very much,
My pleasure.
Dr. Mehta.